So actually, myself and Layth, we reviewed the cervix plan and contours. And thank you for everybody who submitted their homework. You know, it was we all have really busy clinics, and especially you guys. You know, you treat a ton of patients. So I want to really thank you guys for submitting what you have. So I'll review the plans first, and then Layth, you will review the contours afterwards. And so me, in a very quick nutshell, I want to congratulate everybody for the plans. They're all very well made plans. Pleasantly surprised. I would say that the vast majority of them, or all of them, would be clinically acceptable with some variability in quality, which I'll try to kind of highlight as I go. So this has been covered several times in the course, and you've probably seen it elsewhere. And it's the CPChop acronym for when you are reviewing plans and how to evaluate plans. And just a nice, quick way to remember how to evaluate them consistently. So I'll kind of go through. I kind of took the same methodology for reviewing the cervix plans that we had submitted, and I'll kind of go through each one step by step to kind of go through these. The one thing I want to kind of stress here is that I'm not going to go through every single plan individually, but if you guys want, if you submitted a plan and you want individual feedback, I have my email at the end of this. You can just email me and I'll send you, sort of the tip or the specific things that I saw for each plan. But here I'd like to kind of go over them in general and point out some things that I noticed. That way I hope nobody feels kind of isolated. Okay, so contours, C for CPChop. So I am a physicist. I will not be reviewing the contours because you don't want me doing that. So Layth will do that in the second part of the session. So for B arrangements. So all the cervix plans had the correct beam setup. So a nice 4-field box. Everybody did that the same way. The doses more or less were very well balanced. So what I mean that is that all the 4-field angles were well balanced. There was no 70, the highest was what, 65% in the laterals, which was quite good. Some plans did have a lot of APPA weighting, and we tend to, there's definitely reasons to do that, but we tend to kind of discourage that because it pushes dose into where your OARs are, right? If you think about where your organs at risk are, it's the bladder, rectum, bowel are in that APPA. The femoral doses, they're pretty resistant to a degree. And so, pushing the APPA dose a lot will tend to increase that. That's sometimes a holdover from, the older days of 2D where you would have equal weighting or equal MUs or equal time setting from the different beams. Whereas in 3D conformal, you want to equally weight the dose, or the contribution to the dose. So the lateral beams will usually have a little bit higher MU and a little bit longer time from the laterals. I think 3 of the plans actually had field and fields, which I'm really impressed with. And it really does lead to a lot better dose homogeneity and better coverage. And I'll kind of point that out as we go. And these don't have to be very complicated, or beam arrangements. These field and fields, usually it was maybe just 1 subfield or 2 subfields at the most, but it really helps a ton. So I'll try to help that out. And in terms of energy, a lot of the submitted plans were cobalt-60 plans, a couple of 6 MV, and a couple plans included higher energy, like 10 or 18. And those really did make a difference as well, and I'll kind of point that out. Okay, so for CPChop, the C of CHOP is for coverage, so PTV coverage. The coverage was quite good in all the plans, right? So for me personally, like a minimum is about 90% coverage of your PTV. That's like an absolute minimum. 3D conformal therapy is kind of difficult to get good coverage sometimes, depending on the patient's anatomy. So 90% is sort of that minimum, and most plans were really good. Here I'm showing a couple of examples where the biggest trouble that people had was in the superior and inferior portions of the PTV. Can you guys see my mouse? Yeah, perfect. So you can see right here, the coverage of the 90, so the 90 is this orange line, 95 is the orange line, the 90 is the blue line. On the inferior portion and on the superior portion, it tends to pull in and down. So, this is sort of kind of the ideal plan. You can see that there's quite good coverage even on those difficult portions. This maybe could be used a little bit better. Again, increasing the energy of your beams if you have that capability, using field and field. Again, if you have that capability, or maybe even putting wedges in these kind of situations. If you put a wedge in, you could try and preferentially push the dose one way or another, either up, superior, or inferior, in order to slosh the dose a little bit to improve that coverage. But that was very common, and even in plans that we used to do in 3D for these pelvic fields, that's often a very difficult spot to get coverage. Another thing about coverage, so these are all the PTV DVHs that I had from all 10 plans that were submitted, and I kind of plotted them all against each other. And there's if you know your ID, you can kind of figure out which plan you are. Hopefully, this gives you a little bit of an idea of where you fall in terms of your colleagues and how the plans were. But you can see right away that there's a lot of variability in these plans, right? So hotspots go from about 47 gray to about 52 gray or 51 gray. Coverage was pretty good at 90. Maybe a couple plans were a little bit lower than that. That's sort of what I would say is the absolute minimum. Here you got about 95% coverage. Again, pretty decent plans. Everybody kind of met that minimum requirement. But you can see there's a lot of variability of how we're prescribing and how we're covering, the PTVs. And I think this is, again, somewhat related to just the machines. The cobalt machines just have a harder time. So you can see all these kind of PTVs with these large shoulders. Those are all their machines, right? That just don't have that same capability to have these sharper drop-offs, but not all. There was a couple plans with the cobalts that were really good. And so this is slightly correlated. I just show you again. This is the same thing. This is coverage. So how much of the PTV is the 95% isodose line covering? So you can see there's a little bit of a trend that the cobalts are a little bit lower in coverage than the MVs. But some had really good coverage, right? There's a couple here that had 99% coverage and not too much of a hotspot. So, what this kind of concludes is that it's a little more difficult to plan with the cobalt units, but it's not impossible. So it just makes you guys have to work that much harder to get these achievable plans. But again, I think they're all clinically acceptable given what they are. So for CPChop, the H is heterogeneity and hotspots. And again, this varied wildly again, and it was very much related to energy. So again, the same kind of chart. These are your cobalt machines. You can see the hotspots were all really around like 111, 110. One little guy here had a good coverage or a good hotspot. Whereas the MB, Linacs tended to have much better hotspots. And again, I think that's using higher energy, sharper penumbra, and field and field, the ability to do field and field. I don't think the teletherapy units have MLCs. I'm not sure. I know some of them do, but I don't think these ones in particular did. So making field and field is much more difficult, but it goes to show you how much energy in field and field can improve your homogeneity of your dose. So one of the biggest things in these, at least, is looking at where the hotspots fall. And so a few of the plans had hotspots in the OARs, which isn't ideal. And so you want to push those out. So this is an example of, hot region, I guess, that's landing in one area only of the PTV, and it's right on the rectum. So if I was planning this, I would ideally have, a field and field that I would come in from the laterals to try and block this out, or maybe put a wedge in to try and push this a little bit further away from the rectum. Maybe, the bladder is a little bit more resistant, so I'd push into the bladder, or ideally kind of have it broken up. And this is sort of a good example here, where the hotspots are all broken up. They're kind of, it means you're pretty flat, your dose is pretty flat on top of this, in this plane. And even in the superior inferior plane, you can see again, there's hotspots are kind of all over the place, meaning you're pretty good at a nice flat dose. But most plans kind of look like this. There's only a few that had hotspots, where they kind of weren't ideal, that could have been shielded with some with some tricks and some planning improvements. So for CPChop, O is the OAR dose, or organs at risk dose. So for the femoral heads, they were met fairly easily. A 4-field box, as long as you're not, your anterior and posterior beams aren't really far open, you're going to meet your OARs for your femoral heads. So those were fine. Looking at the bladder, again, this is like a composite of all the different plans. You can see, interestingly enough, right, they're a little tighter than the PTVs tended to be. The PTVs are really spread out. The OARs for the bladder and the rectum were pretty kind of clustered. And again, for bladder, rectum, and sigmoid, you're only shooting to 45 gray, so you're not hitting any of these sort of traditional constraints that we would look at. But that said, we often, even if we're past, or even if we meet our criteria, we try to kind of keep plans as good as possible. So it's this ALARA, I don't know if you guys have heard it or talked about it, but you want to keep the dose as low as reasonably achievable, right? So if you can push the dose down, always try to push it down. And so hopefully you can kind of look and again, identify which plan was yours and kind of compare to your counterparts to see, oh, maybe I could do a little bit better between the rectum and bladder, even though all these passed technically. And the idea is that you always want to push the dose down because you never know what's going to happen in the future, right? You might come in and the patient was going to go for an HDR, but in the end has to go for an external boost. Now, if you had a plan that satisfied the OA or satisfied the constraints, but wasn't optimized, wasn't the best it could be, now you're gonna have a harder time with the boost plan. Or if there's a reach treatment, it's the same thing. You're gonna be coming in and you're gonna have more dose than you could have, and you wished, in the past you had done a better job. And then finally, again, other cancers, same thing. If you're going back to retreat, you're gonna be treating the same area. It's always nice to have a lower dose at the beginning. So one place where some of the plans were a little bit spread out is your bowel constraints. So these two constraints of 180 cc's receiving 35 or less, and 180 or 100 receiving 40 or more rather. You can see they kind of fall right into where all the DBHs kind of separate, right? So that's this yellow one and that's this one. So you can see a few of the plans were below that, which is great, and most of them weren't. And so this kind of differentiated a lot of the plans. And this was interesting. I couldn't really figure out if this was due to the MV versus cobalt, but it turns out it wasn't. It was because a couple of plans were just a little bit tighter on the 40 gray and a 35 gray. And so you really want to pay attention to your conformality. Okay, so the benefit of 3D conformal radiation therapy is that you can actually see where the doses are going. You can see how tight they are, and you can try and play that, right? So you can adjust your MLCs, you can adjust your weighting, you can put wedges on, you can do what you need to shape that dose to start to preferentially pull away from areas where you don't want. So this is an example here of a 40 gray isodose line of this patient. You can see it's very generous to where the PTV is, and a lot of that 40 gray is going into the bowel. Whereas on your right here, you have a tight 40 gray around the PTV. You can see substantially less bowel is being irradiated by this 40 gray line. And so the 35 gray line obviously follows below that. The coverage for this one on the left was the PTV got the 95% of the isodose line was covering the entire PTV, 100%. So this is a very generously covered plan. So if I was doing this plan and I wanted to get really nitpicky, I could say, well, you could probably pull that coverage down. This one was covered at 95%, which is kind of still acceptable. But you're going to reduce your toxicity potentially for your bowel. But again, this is often a clinical decision that you would, if I was working with Layth, I would kind of come back, I would show him these two plans and say, this one's 100%, but I got a little bit of hotter bowel. This one's 95%, but I'm really tightening this isodoses around the bowel and meeting my constraints. What do you think you'd prefer? And then Layth, from the clinical side, could make this decision saying, okay, this patient's already suffering, is on chemo, is already suffering, some toxicity, so let's go with the more conservative plan, or vice versa. So that's sort of the approach that I would kind of take. And this is a good example of how just paying attention to where your isodoses are can really buy you a lot in terms of OAR dose. And finally, the last acronym, or last initial for the acronym CPChop, is prescription. So almost all the plans, so 8 plans had the 45 gray in 25 fractions. 2 of them had 20 fractions. So unfortunately in Prono, I can't figure out what the prescription dose, but I'm assuming it's 45 gray that was delivered in 20 fractions. And so I'll let Layth speak to that after in the second part, maybe if that's an appropriate kind of hypofractionated, slightly hypofractionated regimen. I've just never seen it. We've only seen the 45 and 25, which almost everybody carried. And again, a little bit kind of harping back to the PTV diagram, or with all the DVHs. So obviously there's a lot of variability in PTV coverage and how we prescribe what is an acceptable criteria. And unfortunately, that's sort of across the field. even, in the West, in North America here, excuse me, I've worked in 3 different sites, and all 3 used different coverage criteria. So it's kind of unfortunately sort of the case. Right now for IMRT plans, we say that the 100% isodose line covers at least 95% of the PTV. And this is for IMRT, which is a little bit easier to achieve. In British Columbia, where I worked before this, it was 95%. The 95% isodose line would cover 99% of the PTV for 3D conformal and for IMRT. And then in Prince Edward Island, another Canadian site, 95% of the isodose would cover 95% of the PTV. So you can see, even in our own backyard, this isn't as, this isn't a concrete way of doing it. And unfortunately, it does lead to some plans being hotter and colder, but ideally, it does make a huge difference. And then the other thing is that depending on what kind of treatment planning system you use, this will be harder or easier to achieve. Like, for example, Eclipse has very easy tools to exactly nail down what you want in terms of coverage. Whereas in other 3D planning tools where you're prescribing to a point, I mean, you don't have the same flexibility, so it's a lot more difficult to achieve these things. So in conclusion, some take-home messages from this is that using a higher energy and using field-in-field techniques or wedges, if you can, and being very creative with them does help to smooth out some hotspots and increase your PTV coverage. Again, paying attention to your isodoses, right? So this is really the bread and butter of 3D conformal radiotherapy, is that you can see the dose and you can actually start to tighten it around areas where you don't want, right? Or where you do need to keep the dose away. And so I would say kind of maybe encourage you to approach it that way a little bit more. Really pay attention to the isodoses that you want and start to shape the dose away from things where you don't. Try to balance the beams at the calculation point or the PTV rather than doing just like a standard, every beam gets the same amount of MUs. And the pulling away of the PTV coverage on the superior and inferior part of these pelvic fields is difficult. And it can be helped with some wedges or some field-in fields, or again, higher energy if you have that. So as a quick summary, I want to say again, congratulations to everybody. These were all great plans. So any of these little differences that I pointed out were pretty small. I think some machines or some plans had room for improvement, but I think it is a limitation to what you guys are working with. So kudos to you. I think all of them were great. And again, I have individual feedback for everybody. So if you want to, I'm not sure how we want to do this if you guys want to send it to Ben, or if you want to email me directly, there's my email, and then I can if you just give me your ID, I think I can just give you some individual feedback for the plans. But again, most of them were great, and I want to give you guys a congratulations for taking the time to do them. And with that, I'm going to hand it off to Layth, unless there's any questions about the plans.
Yes, let's pause for a minute or two and give everyone the opportunity to ask questions if they have any about what was just covered.
Piotr, I thought that was excellent. Thank you so much.
Thanks, no problem. I was going to try and do something individually, but I think it's probably better served if people want, any feedback. How do you guys want to do it? Do you want them to email you, or do you want me to write up a little report for each of the cases, or?
I can provide you the emails that correspond to each plan.
Oh, that'd be great. Yeah, I can send that out. That'd be perfect.
Great. And then you could copy me and Tia maybe on each email so we can be in the loop.
Awesome.
So I know that you guys just did a example chart rounds in the last session. So this is another place where having a chart rounds is a really great opportunity to get feedback on the plans that you've made for the patients, and to be able to, if you have like a multi-clinic chart rounds and share data from each of your clinics, other clinics can offer insight into the quality of your plans and if they would do anything differently. So this is kind of another example of a really great way to get feedback on your plans and on different aspects of plan quality. So hopefully this has been helpful for you guys. Okay, so if there aren't any questions yet, then we'll move on to Dr. Layth and the contour review.
Hi, everyone. I would like to share the screen now. So just correct me if I'm wrong. This is like the one that I'm supposed to review, the cervical case.
Yes.
All right. So like, who did these targets, like the participants or one of them, or?
I believe that each one corresponds to one participant.
All right, good. So before like doing any review of the volumes, every like radiation oncologist have to put in mind the clinical scenario, and this means that the clinical stage of the patient, the circumstances of the presentation, the clinical examination, the radiological images, including the CT, MR, and PET CT scan, if available, and then come to the final stage and a plan in head what to cover, and what's the dose, and what's the combination of the plan, whether this is a combination of the external beam radiation therapy with brachytherapy for an intact cervix, or this is post-operative radiation therapy with the addition of boost so it depends on the scenario of the patient presentation and the treatments that have been done for the patient. So this patient is a 50-year-old who presented with the abnormal like heaviness and bleeding. And after investigations and assessment, clinical examination, she ended up with a stage 2, and there is no lymph node involvement. We have to keep in mind that the stage 2, there is a possibility of about 30% having pelvic lymph node involvement, microscopic disease, and also 20% possibility of having para-aortic lymph node involvement. So it is also a considerable risk that need to be put in consideration when you are planning your radiotherapy, because your radiotherapy will be a definitive part, would be the curative part. It is not an adjuvant part. So this means that your treatment is supposed to cover like all the visible and the microscopic disease in order to achieve the possible cure rate of about 65% of this patient. So if we will comes to the baseline like volumes of this stage, we need to identify 3 things: the gross tumor volume, which is the tumor that is identified visibly in the screen. For example, this is obvious that this is the gross tumor volume. It's not like optimally visible here. Maybe if we will have the PET CT scan and make the fusion, or the MRI and make the fusion, it will be more optimally visible. The CTV1, it will include the cervix, the GTV, the entire uterus, and the upper part of the vagina. And then the CTV2, it will include the lower part of the vagina and the paravertebral and tissues. And then the CTV3 will include the pelvic lymph nodes and para-aortic lymph nodes. And in this case, with the high probability of having involvement of the para-aortic lymph node, ideally, I will include also the para-aortic lymph node. So this is in mind. After that, I need to put a margin. For the CTV1, I will add 15 millimeter margin to conform the PTV1. For the CTV2, I will add 10 millimeter margin. For the CTV3, I will add 7 millimeter margin. I have to also make my attention to the volumes at risk, including the bladder, the rectum, the femoral heads, and the bowel. And yes, so all these like to be in mind. After that, I will combine the PTV1, PTV2, PTV3 in what we call it PTV sum. And then I will like put my plan to or put my prescription to the Piotr or any other physicist that I will need to cover this PTV sum with the, for example, 45 gray in a 25 fraction. Regarding the fractionation of 45 in 20 fraction, I'm personally not aware about this fractionation, and I didn't use it before. So it will be a good idea if someone who is using this fractionation to inform me or update me about the evidence or the protocol that they are following in this fractionation 45 in 20. I feel that the squamous cell carcinoma of the cervical cancer is well responding to the 1.8 to 2 gray fraction, the conventional fractionation. So I feel comfortable with the 45 in 25 fraction, more than the 45 in 20 fractions. So let's go ahead and we'll review some of the the volumes here. So we need to determine the volumes here.
So Layth, if you click on the left, click structures.
Structures. Yes. Yes. Here you go. So let's so all these, okay. So start with the CTV1. So it seems that CTV1 is not done.
That's correct.
Yes, so we need to identify the CTV1 because the CTV1 is important. This is the higher risk of the volumes that you need to identify and to add 15 millimeter margin to this targets. So this is number one. And the CTV1 ideally will include the visible tumor, the cervix, and the entire uterus. And I can see here in the sagittal that the upper dome of the uterus is not contoured in the, I mean, even in the CTV2 is not contoured. So like in the CTV1, there is no CTV1 which should be done. And if we go to the CTV2, there is a missing of some slides here in the upper part of the dome of the uterus. So so this slide is missing, and the other one is missing also, and the other one is missing here. So there are a couple of slides that we need to cover. This is the last slide here. So, and this is more obvious here on the sagittal view. If we go to the CTV3, CTV3 is also not done, while CTV3 should ideally go to the lower vagina and the vaginal parametrial tissues. So we need also to include, sorry, that is the CTV2. The CTV3 is the lymph nodes, the pelvic lymph nodes and the para-aortic lymph nodes in this case, which is also like not done. So we need to fix this later on. If we go, they put here GTV. So this is GTV cervix. I'm not sure that this it's maybe over contoured, that this whole region is the GTV. So I think this need to be refined. And usually the GTV in the CTV, in the CT scans, is not well like visibly this or like contour. So maybe to concentrate more on the CTVs, because the anatomical demarcation of the CTV is more obvious than the anatomical demarcation of the GTV. If we comes down to the PTV1, there's nothing here for the PTV1.
I think that this example may be not fully finished. So I suggest maybe we look at a case that is more complete. So on the left, top left, click patients.
Top left, patient.
Now, in the where it says 2D to 3D EBRT in the top left, in gray letters in the white box with the down arrow, the very, very top. Very, very top, up. Yep. Now click homework 4. This is the contouring homework workspace. And this is where most people submitted their assignments. So I suggest maybe starting with AA329 final.
AA3.
Yes, this one looks more complete to me.
All right.
And click structures on the left. Good. Let's try that again.
Yes. So we'll start with the GTV. All right, maybe we'll changing the window level to see. Yes, it's really hard to exactly like determine the boundaries of the GTV and on the CT unless there is like a fusion with the MR or the PET. Let's move to the CTV1. Yes, here the CTV1 is better. I'm happy with this. Good. CTV2 is the vagina and the paravaginal paramaterial tissues.
I have one question. So I think that few centers have consistent access to MR or to PET scan, in which case they're left with just a CT scan and they have to contour the GTV. How do they deal with that uncertainty? Does this look like a good guess for the GTV, or would you be more generous or less generous?
So the important thing is the CTV1, which will include the GTV, because this will include the whole organ. So when you are like have a complete CTV1, so this will include the complete GTV. So I think this is the best solution to make sure that you will include the GTV and there's no extension or there's no miss of the GTV. How you feel, Ben, about this?
I think that's good. You know, normally you would, for this, you would follow with a brachytherapy boost.
Yes.
If you don't have brachytherapy, though, is it more important to contour the GTV, or will you just rely on the CTV one?
There are some missing here for the CTV1 anteriorly to the bladder. If we go to the CTV3, yes, this is good for the pelvic lymph nodes. Usually we follow the vessel and then we add 7 millimeter to the vessels. And they cover till like the L4, L5, which is like acceptable. And some centers may, because of the T2 disease, this like the risk of having the para-aortic lymph node is reaching to 20%, while in the stage 1 it's just 5%. So it's up to the the treating physician, but minimum is the pelvic lymph nodes, which this is the risk of having pelvic lymph node microscopic disease is 30%. So
now, Layth, I think you mentioned something very important, that we need to include a 7 millimeter margin on the vessels for your CTV to be complete.
Yes, so this is like from the vessels you need to add 7 millimeter to, yes.
So maybe we can show what that looks like just on a few slices. So if you click Edit Structure Set on the top right, in the blue box, Edit Structure Set.
Yes.
Good. Now click on CTV3 on the left. Make it visible. Now move your mouse a little bit to the left to click on the actual word CTV3.
What do you mean?
Click. Yep, just click. Great. Now you can edit with the paintbrush on the top. Yes. Good. And now show what do you mean by having a margin?
So we have this vessel here. This is the vessel. And you need to add 7 millimeter margin. So you have to contour the vessels, and then you add the 7 millimeter margin, and you need to respect the bones and the muscles and the bowel to cut down the 7 millimeter margin. So this is will be the CTV for the pelvic lymph nodes.
I think if we scroll down to the external iliacs, so here you can see there's a little bit of a margin on the left side, but it looks less than 7 millimeters, and there's almost no margin. So yes, you're at risk of having recurrence anterior to the vessel without
proper anteriorly here.
So can you click and show how you would expand it?
So for this example, this is my vessel here. Sorry. I will do, if I will have the ball of 7 millimeter, this will be better, or at least I will contour the vessels themselves, and then we'll add 7 millimeter margin to form the CTV3, and then I will cut it from the muscles here and from the bladder here. And if there's a bowel also, I will cut it. So, but this is one of the solutions to make it. Also, for example, here I can cut it from the muscles.
Good, yeah, and it looks like that right side needs some more margin on the vessel. This is a very important concept. It'll affect how you contour almost every pelvic case. So
yes.
Good. And then how about on this on the left side? I see there's a, okay. Now, how about the presacral?
So the presacral, you can go down to lower border of S3. So we have like this is S1 and S2 and then S3. So with the end of the S3, I think there is no presacral. So we have some missing here. Yes. How you will like do it here, then in your center?
Go to the lower border of S2.
S2 to S3.
Mm-hmm.
So this is one, the last one here.
I would go down. I would go down one more. Yeah, about here.
Yes. So middle of S3.
Yeah. So yeah, if you're looking at the anterior.
Anterior is between S2 S3.
Yes. And
Yes.
if you look at the posterior, now you're mid S3. So it's just because it's angled. But yes, so I would draw that and maybe show how you would fill in the missing presacral here in the center. So this is very important because the lymph nodes will sort of travel along the ligaments and get into this presacral space. And if you don't cover it, you'll have failure there, and it's a very difficult spot.
It is even more important in the rectal and the prostate case.
Mm-hmm.
Yes.
Good. Okay, so I think that's a good learning point maybe for this case. Maybe we can turn and look at another example.
So we go to the PTV margin. So this is for PTV1. They added, I think, 15 millimeter. Yes. Sorry, it depends on the setup from place to place. So like 3 to 5 millimeter with the.
Yeah, in this case, we instructed PTV expansion of 15 millimeters for CTV1, 10 millimeters for CTV2, and 7 millimeters for CTV3. And I think they did a good job here.
Yes, maybe for the bones, you may just cut it not to go deeper to the bone. So I think 3 millimeter is enough to the back. There is no point to include the whole 15 millimeter in the bones.
Let's see.
10 millimeter.
We have a good question from Dr. Mohammed. If we can preserve the same volume of bladder during treatment each day, can we remove the parts of the bladder instead of the PTV?
No. So even if you will able to preserve the same volume of the bladder, because there is interfraction changes and the interfraction changes, and it's really even on the same person and with the same instructions, it's really hard to keep it on the same like scan or simulation scan at the time of the simulation. So the bladder is very changeable structure, whatever you will do. So I don't think that it's safe to decrease the margin. What do you feel, Ben?
Oh, I don't have experience with that yet, so I don't want to comment beyond my level.
Mm.
I would agree that we typically wouldn't remove any of the PTV from the bladder, but I would emphasize that I think it's really important to try to preserve the bladder volume as much as possible, even though we can't guarantee the exact size and position of the bladder during treatment. A good technique often is to use a bladder fill for stimulation and for treatment, and that way you can kind of control how much volume the bladder is going to have. And by using a bladder fill, you can increase the size, you can increase the volume of the bladder, which will really help with your dose volume constraints when you're planning. So if you have a bigger bladder, you have more volume to play with, and so you can achieve your dose volume constraints more easily, and not hit those maximum dose constraints without having the ability to cover your PTV. So that's a really good thing to keep in mind when you're treating the pelvic disease sites, is organ filling,
Mm-hmm.
how you can use it to your advantage, and how to keep it in the back of your mind when you're defining your PTV and how much movement you expect.
So Layth, maybe we'll go to next patient. If you click on patients on the top left, good, and let's do click name, so it'll organize by name. Good, and let's do AA 331 final. 331 final, yes. And again, we'll click structures to see the structures on the left. Good. And so I think this case is a good example of if you turn all of the structures on.
But here's like there's some wrong for the, this is not.
Yeah, so you have to be careful about stray drawings, because even if you have one speck of GTV somewhere where it's not supposed to be, then later when you do your expansions, that becomes dangerous.
Yes.
You're left with these large PTV specs. So let's show an example. So now show the CTV one, and show the PTV one.
So here, like, regardless of about the accuracy of the contouring, the GTV shouldn't be out of the CTV. So you see in this slide, in this slice.
Mm-hmm.
So this is not the CTV2. This is, yes, goes down to the, so some inaccuracy. And there are some missing, or this is not the ideal contour.
Yeah, so can you comment what's wrong with this, with the CTV3?
So CTV3 here is missing the, like, the presacral, the external.
Mm-hmm.
Mm,
Do you think maybe this person thought that, well, since my other structures are already, my other targets are already covering those spaces, do I not need to cover that space with the CTV3 and only cover the extra space that wouldn't already be covered?
no, it should be like systematic.
Mm-hmm.
Yes. So, mm, yes, this is really,
I think one thing that's important is when you're evaluating the plan, even if the same areas are getting the dose, if the structure is not contoured fully and not correctly, then when you're reading the plan evaluation, it's going to look, it's not going to be representative of what's actually happening.
right.
Mm-hmm.
Yes. And if we go to the organs at risk, I think we mentioned some. So the rectum here. So usually for my rectal contour, I go down to the level of the ischial tuberosity, like this level.
Mm.
So here there is no rectal contour. And then
Mm-hmm. Yeah, so it's very important to make sure your rectum is going all the way down.
it's to the rectosigmoid junction.
Because if you miss drawing it down in that area,
So
there could be
here,
hotspots.
for example, you have the CTV and you have the PDV, and there is no like contour for the rectum. And if the planner is doing the plan without such organs at risk, the rectum will be neglected for the plan evaluation, and it will receive the full high dose without any like avoidance. So we need always to be careful in the contouring the organs at risk. If we go to the bladder, bladder is relatively good. Yes, no much comment about it. For the bowel, so I don't know why they are cutting the bowel and didn't to interpolate in between them. And here also, I prefer to go to the other structures. How can I edit this?
Click Edit Structures on the top right.
On the top right, yes, here.
Now click on the structure that you want to edit on the left.
Yes.
You need to click on the word bowel on the left. Yeah.
So we need to like contour. Well, this is.
Yeah, correct.
So for example, this is like, could be reasonably good.
You want to make sure you're not
Oh.
accidentally contouring vessels as bowel.
Yes.
And sometimes it's hard when you look at a single slice, but if you scroll up and down and you trace the
Yes.
vessel, you can tell what's vessel and what's not. And the psoas muscle is not
Yes.
bowel. So when in doubt about the bowel, really scroll up and down. Sometimes it's
Right.
really hard to tell if you just look at a static slice.
Yes, so we need to fix this issue
Mhm.
about the bowel.
Okay, maybe we look at another case.
Just let us finish this and see the femoral heads, how they. So the right femoral head is good, just the femoral head. The left here, they included the neck and the, so when we are like dealing with the femoral head, is including the femoral head itself. So like what they did here for the right side, not for the left. Because our aim is to prevent or to minimize the risk of the avascular necrosis of the like femoral hip joint. Yes, so I think we mentioned something about the rectum and the bladder and the bowel and the, yes, so I suggest that before every case of contouring to review the guidelines for the contouring. And I wonder if the guys have this copy of book. I will share the screen of this book.
Is this feedback helpful so far on the contours?
I can share a copy of this book. The target volume delineation for conformal and intensity modulated radiation therapy. So it's a good book, and it's organized in different systems, and that you can use it. Right? Is this feedback is useful to the colleagues? Any question? Because I have another meeting.
Can I be made co-host? I would like to share one more case.
All right. Can I leave, guys? There is no more.
We'll finish here. So I know. Thank you so much, Layth.
All right.
Great. So
we'll just keep it silent to respond to the call. All right.
Okay, great. So I want to take a moment to look at one more case here. And, you know, I know for some of you, this is your first time really making an effort at contouring. You know, you're about to transition to 3D, very exciting, but even, you know, just glancing at this looks so confusing. If you're looking at the sagittal view and the coronal view and so many different structures. So, you know, for those of you that are doing this for the first time, I think overall, you know, a lot of you did a really good job. You followed the instructions, you were able to create the expansions from CTV to PTV. And, you know, at the end of the day, the plan should look something like this. It should look quite busy. You'll see a lot of different structures. And this is what what a complete plan looks like. Now, there are some small details. I think some of the recurrent patterns that I saw is that for when we're tracing the vessels, that sometimes we traced them too exact. We need to make sure that there's that margin on the vessels. So if you don't remember anything else from today, remember that you need to have a 7 millimeter margin on the vessels, because you're going through so much effort to make this plan, and this patient's coming to see you, and you want to do them the best you can. But it would be a shame to have failure around the vessels. Remember, we're covering the lymph nodes. So the lymph nodes are not inside the vessels. The lymph nodes follow the vessels. They could be in front of them, behind them, to the left or to the right of them. I think another important point is that your GTV cervix should always be within your CTV. So if you feel that this is your GTV, an easy thing to do. So one thing you could do is you could try to contour and trace it and make sure that everything's exact. But another thing you could do is you could Boolean them just to make sure. And this will be a, let's see. You can do a Boolean of your CTV1 and your GTV. And now you see this yellow structure is a CTV that makes sure it includes all of the GTV. So yeah, just a little trick which you can consider using. Really quick, just OARs, since we didn't focus too much on the OARs. This is the correct ladder, and this is well drawn. For the bowel, it is appropriate to do a bowel bag. So a bowel bag, isn't perfect, but it's most important to have the bowel accurate, close to where you're having your target, in this case here, and you want to make sure that your CTV3 is not overlapping with the bowel. So in this case, I would subtract it here. You see this? I'd make sure I'm not missing any prevertebral space here. Here where the presacral lymph nodes are really important. You always have to remember to include those for these cases. And you can tell what view you're at on the sagittal, or what level you're at. So this is our S1, this is our S2, and S3 isn't until down here. So really we'd be covering the presacrals all the way to you get down here, and everything else above it you would want to make sure that you're covering. So everything down here you're covering. Okay. Good. And then let's check the rectum one more time. And so this is good, where we start to have an anterior movement of the bowel is where we transition from the rectum to the sigmoid. So this is well done. And then we can see our sigmoid continuing. And yeah, that looks pretty good. Now the rectum, we saw that some cases didn't bring the rectum down far enough. So we want to make sure that we're going all the way down till we get to the anus in this case, since our targets, after we do the PTV expansions, are extending quite inferiorly. So all the way down. Good. So overall, this was a good rectum. I would be just a little bit more generous there. And then you want to make sure your rectum is not overlapping with your CTV. So, you know, you would take a look at this and decide where does the rectum finish? Here, maybe not there. And then for your CTV, you want to make sure that's not overlapping with your rectum. Okay. Good. Is this helpful?
And we have a question from Masood. What about the parametrial boost in the case of homework?
The parametrial boost in the case of homework?
Yes.
Sorry, I'm not sure I understand. In the case of homework?
So in the case that was given, the way I interpret it, in the case that was given for homework, or what about the parametrial boost, or is there a parametrial boost?
I don't recall. Sorry, you're asking me a hard question. Give me an easy question.
Maybe Masood can clarify.
In this case, I don't think that there is indication for a parametrial boost, unless like maybe Masood is asking about something else.
Let's see if he replies.
Okay, any other questions or comments? You know, I do think that in general, you did a good job for CTVs, keeping them out of the bone and out of the muscle. So, you know, here you can see that they're not getting into the pelvic sidewall muscles. That's good. And here they're staying out of the bone. That's good. And then when they do the PTV expansions, it's okay to go into the bone and into the muscles, because this is accounting for uncertainties in position. Yeah, so I think we're sort of at time now. I think I guess Tia will moderate me, but I really think that Piotr did a nice job showing the different plans that we had here. And, you know, I think these plans are based on the contours that they were given. So you need to, it seems like the physicists are ready to make good plans. But in order for the plan to be good, you also have to make sure you give them the right contours. Because if you do a good plan on bad contours, then it's actually going to be a bad plan for the patient.
Correct.
And that's correct, Bistun. There's no spinal cord below L2. And the cauda is very resilient, so generally you don't need to worry too much about dose there, and unless you're in the setting of reirradiation.
I have to add something, Ben, here. And like many of the cancer patients, they are surviving a long time now. So it's better to always preserve the bone marrow as much as possible. So especially in the era of IMRT and even the 3D, we need to protect as much bone marrow as possible. So it's good to contour the bones because the lower lumbar and the sacrum and the pelvic iliacs carry high percentage of the bone marrow in the whole body.
Mhm.
So it's good to contour the bones and the bone marrow, or you can just use the surrogate of the bone as the surrogate for the bone marrow, and then try to enter the constraints as a risk organ. And by this, you will preserve good volume of the bone marrow, and you will not deplete the bone marrow by the radiation therapy.
We have a question from Nash. Kindly show me how to create a PTV45.
Okay. So at the end, if we go in, let's look at this. So see this last instruction down here? Boolean the PTV 1, 2, and 3 to get the PTV 45. So what Dr. Wakefield means here is he means add up PTV 1, PTV 2, and PTV 3. The sum of these structures is going to be your PTV 45. That way your planner can prescribe just to one connective continuous target. So to do this on Prono, you would click create structure. And I'm going to add, I can only add 2 structures together at a time here. But in other planning systems, you can add multiple structures at a time. So here I've added the PTV1 and PTV2 together, and now I need to add the PTV3 into this. So this is a little bit clunky. Prono is not meant for, at least not yet, for replacing your planning system. But this is how I would do it in this system, just to show you. So I've called this PTV 45 actual. And now, let's see, we can see this pink? So this pink is our summation of our PTV1, PTV2, and PTV3. And this is what your PTV 45 is. Does that answer your question?
Yes, it does. One more question. It is mentioned in this case that there is involvement of the upper third of the vagina. So is it mandatory to treat the inguinal lymph nodes?
Layth?
Usually, like if the cancer goes down to the lower third of the vagina, then it will include the inguinal lymph nodes, but not the upper third.
Mm-hmm. And if you remember, this is notes from Dr. Wakefield's presentation for intact cervical cancer. And he writes, if the distal third of the vagina is involved, then
Yes.
the inguinal nodes must be covered.
Correct. The distal third, not the proximal third.
So,
Or
you know,
upper.
you have these instructions from Dr. Wakefield. I would keep these open as I'm contouring to make sure I'm following each of the instructions, but it's very specific and can help you.
I mean, contouring the lower third, it doesn't mean that you will treat the femoral, because the contouring the lower third as part of the CTV3 and CTV2 doesn't mean that the tumor itself is extending to the lower third. So you have to treat the femoral or the inguinal.
Mm-hmm. Okay, good. Lots of rich resources for you.
I think this was a really great session, everyone. I hope that you found it helpful.